Thank you.
Good morning. Welcome to our commission hearing. We would like to not only welcome all guests, but start with several official protocols we must do. So to begin with, we will start with our commission roll call.
Commissioner Edelman? Here. Commissioner Gaskill?
Here.
Commissioner Costa?
Here.
Commissioner Frank? Here. Commissioner Goodall?
Here.
Commissioner Jensen?
Here.
Commissioner Lindeman?
Here,
Commissioner Parker Martin? Here.
thank you very much. Given that we do not have a quorum of the commission today, we'll proceed as a committee and not take a formal action, but we'll be hearing testimony. So with that, before we start and have some opening comments and a little housekeeping, we'd like to ask all colleagues here who may and are able to stand to join us for a pledge of allegiance. I pledge allegiance
to the flag of the United States of America,
to the republic for which it stands,
one nation, under God, justice
for all. Well, good morning and welcome to the Commission on Aging's informational hearing entitled Nowhere to Go, Addressing the Crisis in Supportive Housing for Older Californians. I am David Lindeman, Chair of the California Commission on Aging, and again, welcome you on behalf of commissioners, our fantastic staff, and all of the individuals who are giving their time today to give us testimony. We're very appreciative of that for this very important session. A few very brief housekeeping before we jump right into our meeting. We have the meetings being recorded. We have a number of commissioners and public joining us online. Unfortunately, we cannot connect or take questions except for commissioners directly to our director, executive director, Carol Schwartzlander. But we will be taking questions at the end during public comment. During the course of the program, after we hear our official positions from our different speakers for our 4 different panels, we will have the commissioners will be able to ask specific questions before we move on. So again, we appreciate all of you attending. We're looking forward to an extraordinarily productive day and a great deal of information to be shared, which really should help drive the future of housing and how we deal with supportive housing throughout California for our very important populations. So to begin with, a little background. California's housing crisis is an aging issue. Almost half of the single adult homeless persons in the state are 50 years of age or older, with 41% of them becoming homeless for the first time in their lives. This emerging trend requires us all to view homelessness and the policy choices we make in housing through an aging lens. Unfortunately, for many older adults, escaping homelessness requires more than just a housing unit. The effects of aging are magnified when an older adult is living on the street. However, providing housing stability for older adults can require a multitude of services and considerations ranging from accessibly designed units and buildings to the need for on-site staff to assist with daily living activities. There is growing concern that significant shortages exist in affordable housing, especially designed for the needs of older adults, and especially those older adults exiting homelessness. Today's informational hearing is focused on supportive housing settings and those shortages that hinder the ability for older adults to be rehoused. Supportive housing has a number of definitions. The focus of the Commission today is to understand that housing for older adults exists along a continuum, and that even more than other targeted populations, providing housing stability for older Californians is not a one-size-fits-all. We will look to a series of experts from across housing representing the community, local and state government, affordable housing developers, and others to better understand the urgency and complexity of this issue. We'd like to start with our first panel, which is entitled, Why Homeless Older Adults Can't Find a Place to Land. and it will examine the difficulties that local homelessness programs are facing in rehousing older adults due to a lack of appropriate setting capacity. I'd just like to mention our other three panels at this time so that we can plan as the morning and afternoon go along. Our second panel is entitled Beyond Beds, Planning for Supportive Housing Capacity in California. Our experts will at that point be from the state level, and they will give an overview of the existing mechanisms used to plan for housing and the landscape of settings that, while not officially considered housing, play a vital role in the housing continuum. Our third panel is entitled What's Holding Us Back, which will focus on the financial and regulatory barriers blocking supportive housing. We will hear from representatives of affordable housing assisted living developers and advocates who will describe the barriers to building supportive housing settings at the pace of our increasing demand. And finally, our fourth panel is entitled Opening Doors, How Emerging Programs Are Growing Housing Options for Older Adults. Our panel of experts will examine the current and future initiatives that can be useful in expanding capacity for older adult supportive housing settings and how these initiatives can be unlocked to their full potential. At the conclusion of our fourth panel this afternoon, we will have an opportunity for public comment to hear from anyone in the audience, and we will request already in the interest of time that comments be limited to 2 minutes so that we can hear from as many people as possible. So with that, I'd like to welcome and delighted to have our three experts for our first panel, Why Homeless Older Adults Can't Find a Place to Land. Basically, we are going to be hearing about, as more older Californians become homeless, the types of resources and programs provided to rehouse them, and these can only work if an adequate supply of appropriate housing is available. Preliminary evidence has suggested that programs which have shown incredible results in stabilizing older adults who are rehoused may be stymied by a lack of capacity in age-friendly housing with available services. To better understand the barriers this population faces in finding housing with supportive services, we'll hear from three experts with firsthand experience in this field. Today we have with us Genelle Cazares, Chief Executive Officer of Hogar Community Services, a contracted behavioral health service provider that provides behavioral health treatment, intensive care management, housing support, peer services, wellness programming, and community-based and prevention and early intervention services to approximately 600 older adults annually throughout here in Sacramento County. We'll also hear from Lucy Kasdin, Deputy Director of Alameda's County Health and Homeless Services, the lead government agency overseeing one of the 10 largest continuums of care in the country, serving more than 25,000 people a year. And we will also hear now from Steve Gaskill, a community member with lived experience in homelessness, currently living at the Wong Center, an affordable income community serving older adults age 55 and older. And so we would like to allow and have Mr. Gaskill start our session. Welcome. The floor is yours.
Good morning, everyone. Thank you for having me. I understand this is a really important meeting. It only happens once a year. And I don't know if everyone got a chance to read what I have written in terms of some questions that Marika had asked me. Just to give an overview, some sense of what my experience has been. Living at the Wong Center has been just such an amazing, fortunate experience. I don't know if everyone is familiar with it, but it sits downtown. It's a 55 plus building, meaning you have to be at least 55 to live there, and has different levels of subsidy for specific apartments and stuff. But I was staying in an apartment before then that was so expensive after moving back from Detroit. And that was like the cheapest I could find was for about $1,300 in Midtown. That I had to do the Grubhub and everything in my older car And what ended up happening was the rent got increased all of a sudden. And I just used that as motivation. Okay, there might just be something else. So I started looking online, and Wong Center happened to have applications at that time. And I remember when I used to live here that money was being set aside for specifically these types of buildings. So in that 10-year interim, I was like, oh, wow, this building is one of those buildings that money that got set aside 10 years earlier finally has come into fruition. I'm like, how fortunate am I to catch it right when they're just about to end. So let me cut to living there. It's a brand new building. It doesn't really have a lot of supportive services. It's not that kind of building that I understand. But it's just such a, as you're talking about landing, it's a landing pad for a lot of older people that there's a old song, "Hey, I got no place to go. I'm alone in a big city. Will you be a friend and help me?" That's a song. And that plays in my mind because now it's about 150 older people. I'm like one of the youngest at 61, and people are in wheelchairs. People have different mobility issues. We call it behavioral health, but I'm not sure if that really captures the confusion a lot of people live in and a feeling of being disconnected. So we're starting to band together and help each other. If I could just point you to the last part of what I wrote real quick. It says, think about this. Let me put on my glasses. We're all aging. Developing effective housing solutions for our aging population will continue to be valuable for the general population. And I was reading a lot of what your reports are is actually talking about this. There are opportunities yet to explore, like young and old partnerships where youth in need of guidance or just someone to listen can be paired with elders with complementary needs. I hold a tech workshop for our residents and have had many appreciate the help where they bring their phones and different things, and we just sit and help each other. But we're all still alive, and we just need a little help to maintain our dignity. So, thank you.
Thank you very much. And again, we commend all people to review the material that Ms. Gaskill has wonderfully prepared for us. So we'd like to next turn the floor over to Ms. Kasdin, who will speak to us from the Alameda County perspective.
Genelle, Cazares, is that? Yes. Okay, thank you. I am going to read mine. I hope that's okay. I do want to thank you for the opportunity today. I think it's a really critical conversation. I'm Genelle Cazares. I'm a licensed clinical social worker, and I serve as Chief Executive Officer at Hogar Community Services here in Sacramento. For more than 70 years, Hogar has served Californians living with serious mental illness, substance use disorders, homelessness, and complex behavioral health needs. Through 3 programs specifically serving older adults, we provide behavioral health treatment, intensive case management, housing support, peer services, wellness programs, and prevention and early intervention services to approximately 600 older adults annually throughout Sacramento. One of the programs is a full service partnership as well. We also maintain ongoing relationships with approximately 200 older adults who have graduated from our Senior Link program and continue to participate in social activities, advisory committees, volunteer opportunities, peer support, and community events. Their continued involvement demonstrates something we often overlook in policy discussions. Connection, purpose, and belonging are essential components of healthy aging, behavioral health recovery, and housing stability. I appreciate the Commission's focus on the intersection of aging, behavioral health housing, and long-term services and supports, because for many of these adults, older adults, these systems are inseparable. It's been asked, what is the backlog of older adults attempting to transition from transitional housing to permanent supportive housing? I can't provide information countywide. However, El Hogar routinely experiences significant delays in locating appropriate housing placements for older adults who are ready to transition into permanent housing. Many of our older adults we serve are living with serious mental illness, chronic medical conditions, cognitive decline, mobility limitations, physical disabilities, and co-occurring substance use disorders. They require a level of support that falls somewhere between independent living and institutional care. The middle ground is missing. We frequently encounter older adults who remain in transitional settings, hospitals, shelters, temporary placements, and other high-cost environment longer than necessary, excuse me, because appropriate permanent housing options are simply unavailable. Many clients in our Sierra Elder Wellness Program, that's the FSP I was talking about, come to us with a 602. That's a physician's report that documents medical conditions, support needs, and that require assistance with medication management, mobility, healthcare coordination, and activities of daily living. Despite the documents, finding appropriate placement is very difficult because available options are either unaffordable, unavailable, or there's an unwillingness to serve individuals with co-occurring behavioral health conditions. It's also asked, is the supportive housing and other appropriate settings restricting the ability for homeless older adults to become permanently housed? I think the answer is unequivocally yes. For older adults, behavioral health needs, housing is often the intervention that determines whether recovery is possible. As behavioral health providers, we can stabilize symptoms, connect individuals to treatment, provide intensive case management, and build trusting relationships. But without stable housing, those gains are difficult to sustain. Permanent supported housing designed specifically for aging adults remain limited. Affordable board and care homes and room and board settings are becoming increasingly scarce and unaffordable. Assisted living facilities and RCFEs, residential care facilities for the elderly, often hesitate to accept individuals with behavioral health conditions, substance use histories, complex medical needs, or cognitive impairments. As a result, older adults remain homeless longer, cycle repeatedly through emergency departments and hospitals, or become unnecessarily institutionalized. Many older adults do not need hospitalization. They do not need locked facilities. They do not need to spend their later years cycling through the system of crisis care. What they need is stable, affordable housing coupled with flexible, community-based behavioral health services. Where do we see the greatest shortages in settings? I see it in 4 areas. Permanent supported housing designed specifically for older adults with behavioral health needs, which is what you alluded to. Affordable board and care, room and board, and assisted living and RCFE settings capable of serving individuals with behavioral health, medical, cognitive, and functional support needs. Prevention and early intervention services that help older adults remain housed before a crisis occurs. And finally, a trained workforce capable of supporting older adults with complex behavioral health and physical health conditions. Housing affordability has been one of the most significant challenges facing older adults. Many of the individuals we serve rely primarily on Social Security income, Social Security disability income, and at the same time, rents continue to increase. Leases are often renewed every 6 months, and housing costs rise far faster than Social Security adjustments. Board and care homes and room and board settings that once provided affordable alternatives are becoming increasingly expensive and inaccessible to those living on fixed incomes. We're also facing shortages in providers trained to work with older adults who have behavioral health conditions. Even when housing becomes available, we need workforce expertise in aging, serious mental illness, dementia, substance use disorder, trauma, co-occurring medical conditions, and culturally responsive care. We talk about the roles, what roles do assisted living settings and RFCEs play in the housing continuum. Assisted living settings and FEs occupy a critical place within the continuum care. For many individuals, these serve as a bridge between homelessness, hospitalization, institutional care, and long-term community stability. They can provide the support older adults need to maintain housing while receiving assistance with medical, functional, and daily living. However, many facilities remain reluctant to accept residents with behavioral health conditions, co-occurring substance use disorder, or complex psychiatric histories. This creates significant barriers for older adults who are clinically appropriate for settings but cannot gain access to them. We need stronger partnerships between housing providers, behavioral health organizations, healthcare systems, assisted living providers, board and care operators, and aging service networks to create smoother transitions and prevent unnecessary hospitalizations. Before closing, I'd like to acknowledge and commend California's leadership recognizing the critical role housing plays in behavioral health outcomes. Through Prop 1 and BHSA, the state has elevated housing as a central component of the behavioral health continuum. Housing is healthcare. Housing is behavioral healthcare. And for many adults, housing is the foundation that makes recovery, stability, and healthy aging possible. At the same time, I believe California missed an opportunity by not explicitly identifying older adults as a priority population within the Prop 1 housing framework. Older adults are among the fastest growing population in California, and we continue to see increasing numbers of older adults becoming homeless for the first time in their lives. Yet older adults often appear to fall within broader categories rather than being specifically recognized for their unique needs. Older adults experience homelessness differently than younger populations. They are more likely to have chronic medical conditions, mobility limitations, cognitive decline, functional impairment, and co-occurring behavioral health challenges. Without intentional planning and dedicated investment, older adults risk becoming an afterthought in systems that were not designed to meet their needs. We must not also lose sight of prevention and early intervention. Many older adults who struggle with depression, anxiety, grief, loneliness, cognitive decline, or housing instability may not qualify for Medi-Cal or may fall just above eligibility thresholds, yet they remain highly vulnerable. As prevention and early intervention responsibilities transition to California Department of Public Health, Hogar's Senior Link program is currently experiencing funding losses because these services are no longer prioritized within the primary funding structure under BHSA and Prop 1. With program reductions occurring before new funding opportunities are fully implemented, there is concern that vulnerable older adults may lose access to services that help prevent crisis, homelessness, and isolation. Social isolation remains one of the most significant risk factors we see among older adults. Meaningful connection, peer support, community engagement all reduce depression, improve health outcomes, and help older adults remain housed and stable. Investing in prevention, housing stabilization, social connection, and behavioral health services before crisis occurs is one of the most effective ways to reduce homelessness among older adults. I encourage the Commission to focus on some points. Expand permanent supportive housing specifically designed for older adults with behavioral health needs. Protect and strengthen prevention and early intervention services, including services for older adults who may not qualify for Medi-Cal, but remain vulnerable to housing instability and behavioral health decline. Increase access to affordable board and care, room and board, assisted living, RCFE settings, equipped to serve older adults with behavioral health and medical needs. Invest in workforce development for providers serving older adults with complex behavioral and physical health conditions. Ensure housing and behavioral health investments explicitly recognize older adults as a priority population. California adults deserve more than crisis response, which is what we're seeing in our programs today. I thank you for your time.
Thank you, Ms. Cazares. Very thoughtful and gave us already an outline for next steps. So we appreciate it. We'd next like to hear from Ms. Lucy Kasdin, Deputy Director for Health and Homelessness Services at Alameda County.
Thank you so much. Good morning, commissioners. Thank you so much for having me here today to speak with you. I'll certainly will be building off of, I think, and amplifying some of what the prior speaker spoke to. So just briefly in Alameda County, which as you've highlighted is certainly consistent across the state, older adults experiencing homelessness, right? They're the fastest growing group of people experiencing homelessness. About 44% of people experience their first episode of homelessness in Alameda County after the age of 55, and often as the result of a crisis, right? Job loss, a medical emergency, or rising rents, which was highlighted earlier. In Oakland alone, which is our largest city and with the highest density of homelessness in Alameda County, over 25% of people experiencing homelessness were over the age of 55. Pardon me, half of the unhoused population is over the 55. One of the things that's really important for us, and I think is to really that integration between health and housing. And one of the things in Alameda County that we've really been a national pioneer in is really understanding the impacts of homelessness on health outcomes. And so I think this also really challenges us to think about when we think about homelessness, but older adults, what somebody who's 50, who is homeless, who's been homeless for a number of years looks like is often in the general population, what maybe a 70-year-old individual would look like. So as you can see, the average age of death among people experiencing homelessness in Alameda County is 52. So they're not even making it to that 55, right? In terms of kind of how we define and think about age. Have very high prevalences, of course, as was highlighted in terms of physical and mental health, which with over 70% of people in Alameda County reporting at least one of those. All right. So a little bit of background in terms of the housing needs in our county. So as we know, older adults, especially those who experience homelessness, have chronic health needs. Our goal, right, is to help support people into who are exiting from homelessness into being in the least restrictive environment, right? We want people to live as independently as possible. So really looking at those that don't require institutional care, but really do need a level of support to be able to successfully reside in the community. Many programs that are many health, right, in our healthcare system, many programs are very difficult for people experiencing homelessness to access. There's a lot of stigma and just logistical barriers that really we know create significant access in terms of accessing care, and often care then becomes very kind of episodic and in response to acute events. And so what we see as a result of that is this real cycling that happens across these systems that aren't able to really skillfully care for people experiencing homelessness, right? Where folks are in the hospital, they have a poor discharge plan, they go to a nursing home that's not able to really care for them, they go back to the streets. So when we think about kind of where we are, where we have been and where we can go in terms of kind of that continuity or that continuum of housing options, really starting with kind of the traditional models of care that we see, right? So people living independently in the community, what can we do to support them? This would include things like in-home support services, right? Those who may be at a level where board and care placement, as was spoken about, residential care facilities, RCFEs, skilled nursing, kind of post-acute, and then of course, end-of-life care. So in terms of these traditional models of care, kind of why don't they work for people experiencing homelessness the way they may work for kind of the general population? I think people are really forced to move through these different systems, which are often very disconnected. Many of these settings, again, are really not set up to successfully support people exiting homelessness, many of whom have trauma histories, if not more significant, mental health, as was lifted up, as well as kind of complex physical health needs. Because of this, people end up cycling through, which is deeply destabilizing, often further, right, exacerbating their health conditions and deepening, of course, their sense of hopelessness, distrust in the system as they continue to just be moved from one place to another. And so and in addition to that, and I'll speak to this a little bit more in slides to come, the accessibility of what is actually available and then the coverage, including what we're able to leverage in terms of medical services to support people, is often very limited. So starting with looking at our permanent supportive housing, this slide does speak to the general population, but also calls out older adults in particular. Again, I thought it was helpful to just to provide it to you all with this context, right, about really where we are in terms of permanent supportive housing in our system. So as people stay longer in homelessness, right, due to the shortage of permanent supportive housing, right, we see more complex needs. In general, across all ages, about 60% of people report, this is self-report, about at least one disabling condition. And then again, 59% in terms of the episode of homelessness. So we see people not only who are getting sicker, but are homeless longer, right? So more people who fall into that chronic homeless definition. So in terms of kind of where we are with our housing queue, meaning how people access permanent supportive housing through our coordinated entry system in Alameda County, just wanted to pull you through. So about 31% of people with those highest needs, right, which is how permanent supportive housing, how we prioritize who is connected to it, are individuals over the age of 31. And so we see, again, across the system, there's over 4,000 people at any given time. In an average year, this was 2024, we had 640 placements into, right? So that means 85% of people who needed that permanent supportive housing level of care were not able to access it in that year, meaning they are homeless on the street or in other settings for longer and longer. There also, in terms of, I think, historically, kind of permanent supportive housing, kind of the inventory to need problem in terms of how permanent supportive housing has been structured. So there's a shortage, as I was just pointing out to you in real numbers, in terms of kind of our permanent supportive housing inventory, right? As that system gets more and more impacted, wait times for people to come into that housing is longer, right? People, that compounds and accelerates those vulnerabilities. Again, people are sicker longer, more trauma, more postponed access to real, meaningful, effective health care engagement, behavioral health care engagement. And so that when those individuals then get into permanent supportive housing, then it becomes less likely that that's actually the right place for them, right? Their level of need and what we can do to support them in that space. We certainly leverage programs like enhanced care management through CalAIM, tenancy sustaining services through, through Medicaid, and then tenancy sustaining services through CalAIM. But again, just how much that level of support is really set up to support those folks. And so traditionally the response has been, and totally agree, we need more, right, permanent supportive housing, and we need to build that and build that quicker. I think one of the things that we're really kind of rethinking that in Alameda County is thinking yes and, right? We like to say that we have kind of an everything all at once kind of way of thinking about this, right? Yes, we need to accelerate the building and bringing on of new permanent supportive housing, but we also need to diversify and recognize and build out a continuum of support. And so thinking about the role of different current models in terms of, right, how they can support. And so one of those, as it was spoken about, are residential care facilities. In Alameda County, we have about 324 beds that are funded by our county. That includes adult residential and our CFEs. And of those, there are 11 specifically with 208 beds specifically for, again, older adults. As was certainly lifted up already, there's a real system capacity in terms of the availability of those beds and the willingness of our CFE providers to work with people who are exiting homelessness. I was speaking to a real local expert about this in Alameda County earlier this week. They said kind of across all of the sites, they think there's about 7 sites in our county that are open to working with with our clients. So again, I think you think about what is true in terms of what is in the system, but then what are sites that really are looking for those pay out of pockets, families, right? Versus who are really open to working with people who may have more significant behavioral health, active substance use, all of those types of things to really be able to successfully support them. The assisted living waiver, of course, certainly supports this, but it's very restricted. Right now in our county, there's about a backlog of about 6,000 applicants for the assisted living waiver. So again, thinking about, yes, that is a way that you can support funding of, and that system is so impacted that the availability of the access to that is again for a very small number of people. We do support, especially for those with higher behavioral health care needs and high health needs. We do provide some county patch funding. Also living in our CFEs also requires individuals to forego, right, their whole check. And so that is oftentimes, right? So there's the barriers of the site and who they're willing to work with. And then there are individuals that in general, people are left with somewhere around $180 a month, right? So that's for phone, activities, clothing, going to, everything. And so it's not uncommon that people decline, right? Even though we might clinically think that that's the right level of care for them, because that is, that leaves them with so little money. Again, thinking about kind of quality of life for individuals. So all of that to say, there are challenges with RCFEs, again, in that everything all at once, certainly they play a key role. And I think for us, particularly kind of looking across our continuum, thinking about individuals with more significant cognitive impairments, those more likely to wander, which is a huge risk often for individuals, that they might be the best place for people versus other options. All right. So on to some things that we've been doing in Alameda County to really address some of these barriers. So one of the things that we launched just at the end of 2025 to meet the immediate needs is new medically enhanced interim housing. So this is shelter that is designed specifically to support folks, many of whom, okay, thank you. Many of whom, of course, are older adults, but have higher needs. And so this provides nursing and caregiving services to really support individuals, so we can immediately bring individuals in off the street, out of the emergency room, etc., into a space. Again, this is an interim space, 150 beds filled up like that, and the ability of transitioning people to long-term is the challenge. The second area that we innovated really starting in COVID was partnering with an agency called Cardea Health, which was actually born during COVID, to pilot what we refer to as medically frail permanent supportive housing, or PSH plus. And so this is a model using a Medi-Cal waiver, the home and community-based alternative waiver, that really allows us to have people in permanent supportive housing, but have nursing and caregiving services that can be flexed up to 24 hours a day to support their needs. I just will highlight a few of what we've seen in the first several years of this in terms of the success we've seen. So 95% housing retention, again, going back to really putting folks, connecting people to a space where they're going to be successful and stabilize and be able to really live. Significant reductions in terms of utilization of acute high cost services. Certainly improve quality of life, the availability and access for hospice and end-of-life care, which is a huge gap for people. All right. So in terms of kind of building off of that, what we see as some opportunities that I wanted to leave you all with. So while we're excited about the medically frail that we've been able to roll out, it really now is at capacity in terms of what we've been able to do to leverage that along with PSH providers, with a current wait list of about 3 years to get new folks enrolled and being at capacity. And so what I would just point you all to is there are several state policy developments that are in the works that we think are hopeful in addressing this. The first is AB 2081. AB 2081 is a bill that is actively working to increase the number of HCBA waivers there are. So right now it's capped statewide. This would allow for a significant increase of this, meaning that then we could expand and be able to serve more adults, more older adults in permanent housing with that, again, increased level of care. The second is very new. It's a Senate bill proposal. It's a budget proposal out of the state Senate called Be Home Soon. And this is meant to really be able to leverage Medi-Cal programs, the assisted living waiver and the HCBA waiver, to be able to really expand those, again, with the goal of keeping adults, older adults in their homes, in their communities, and in the least restrictive environment. Thank you so much.
Well, and thank you for, again, giving us not only some of the background issues, but some of the new mechanisms that are currently on the table for us to consider. So we have approximately 20 minutes for additional questions to the three of you. We'd like to open the floor to the commissioners, and we're getting a few questions from our colleagues online as well. So I will continue to look for comments coming, but one from our first commissioner, from Commissioner Davis, who is not able to join us today. And it goes to all three of you, that when, as you've described this to us and described not only the challenges, all the specific areas that need to be addressed at once, this continuum, when it's put all together, is there a way to simply describe it as to what would it look like when we get it right, as she would put it, with all this work and the resources that you either need or you feel you're putting together or would like, what would it look like if we were to put it together as a package to allow people to live well? So we open it to the three of you for your respective perspectives.
Aldo.
Please.
If I understand the question correctly, I do want to start with prevention and early intervention. It really does support people from moving into crisis. With that said, we have RFS, our full service partnership that serves older adults. They have medical health conditions. And if we could provide the support that's needed in permanent and supported housing, but also in their own homes. So having the support services in their own homes with families that are unable to take care of their needs, and then have that higher level of service, but the opportunity then to step back down into a lower level of care of service need, once stability, whether it's behavioral health or medically. We have people who are stable from a behavioral health perspective, but we're often, how do I say this? SNFs, RCFEs, other entities will not take our clients, which then prolongs care. So they land in the hospital. So if we could have that continuum that provides an intentionality and with intention to step people back down to the most independent living of care, and that might mean needing supports. That might mean needing people going in to prioritize behavioral health or medical, and provide them with a social connection that's so desperately needed with this population, even back to prevention and early intervention. And I'm kind of sad to see the prevention and early intervention isn't part of that continuum of care, because it really does support the need in the moment and then stepping back into where a person can remain and consistently healthy, even with really fragile conditions. We talked about end of life. That our program, we see so many people lose their lives early on, but also because they're older adults. And we provide those services, but we're not really trained to do that, right? We're not trained to do that. But if we could have that continuum, I think that would be fantastic. Does that answer the question?
That's a wonderful start, particularly with the emphasis on prevention to really head off all of the issues that we're talking about today. Mr. Gaskill.
So I really appreciate that because I was learning a lot by listening. And one of the things that stuck out to me was a continuum of care that is based upon probably a good assessment of where each family situation is, how prepared people are to grow old. It sounds so simple, but we're not prepared mentally. We're not prepared situationally. I had missed the opportunity. I didn't think about it all the way through about reading what I wrote, but I can still pick from it. And one of the situations is that um, there are people that in my building that just wander because I heard someone mention about wandering. And what's wrong with that? The idea of just walking is fine. But what seems clear is that this one woman, and she seems so sweet, she doesn't seem to be fully cognizant of her surroundings and stuff. And so a lot of us are really concerned. But this is not the type of building that has the support services. So there's a big gap then. She can speak, she speaks another language primarily, and she can walk, but where's her family? Some of us don't have children. There are these assessments then of, so where are these California situations, our California families and individuals, which will be a family, like I'm a family of one at this point then. This family is not situated to take care of myself as I'm aging. So I'm educated enough, I guess, and aware enough to think about what's going to happen. But I'm much more fortunate than a lot of my peers who are not really aware. They're not thinking about it. They're just on their phone and watching TV and not really even aware within the next 5 years, some of the changes, the dental changes, vision changes, cognitive changes, to even get prepared for that. And plus, we live in a society that prioritizes freedom of individuality, which I fully support. And then we're stuck in a bind because how do we provide support? You can't impose support. And so I'm very open-minded, and we have to use the and both. I think someone said that we have to combine. I really love even asking young people this question. You will age, you'll get older. Think about how you want that to look, which I think that's what this commissioner was asking us. But I have to admit, I don't really know. I just know what I see. And maybe that's the contribution I can make, is that we need to do better assessments of what's the capacity is.
Thank you for reinforcing the importance of the diversity of support systems or support network for each person, of the diversity of planning and how we age, and even the underlying issue of dementia, which is going to be an underlying theme as we discuss this today. Thank you. Commissioner Castillo, a question.
Oh, you didn't what? Is there one more?
Oh, please, we can
Oh,
open for additional comments.
I just certainly echo what they say. I think we're excited actually in Alameda County launching new senior targeted prevention starting in July. Again, prevention, right, looks different at different ages. So really recognizing and being intentional about having prevention services specifically for older adults. And then what do those interventions and supports and networks that need to be created. And so, yeah, I just echo what others say. I think it's the dream is about, to me, having a flexible, responsive, individualized system that can meet the needs, which change in both directions over time for people.
Thank you. Commissioner Castillo.
Good morning, panelists, and thank you for your time today. My question is, what specific amendments or recommendations would you make to the California Department of Social Services, Title 22, Division 6, Chapter 8, that dictates the admission and assessment for RCFE providers that could enable more providers to accept higher acuity residents and offer the training that the residents need, person-centered care? Thank you.
Sure. Yeah. Okay.
Either way.
I don't know that I'm going to speak transparently. I don't know Title 22 to that degree. Can you ask the question though again? Because I do think we can respond despite that.
Sure. What specific amendments or recommendations would you make to the California Department of Social Services, Title 22, Division 6, Chapter 8, that dictates the admission and assessment criteria for RCFEs that could enable more providers to accept higher acuity residents and offer a curriculum to educate team members and care staff to offer person-centered care?
I almost feel like the answer is in the question. Training people to work with older adults. I do think that there's a limitation due to the lack of expertise, and especially as is about people who come to us with behavioral health and co-occurring. And then I'm glad we're talking about dementia a little bit later because there's that overlap, right? What part is a behavioral health condition? And as we get older, what is dementia? We have a psychiatrist on board who can really help discern that. So I think those assessments that you spoke about are really critical, but also it's a complex population. So being open to receiving, but it is also expensive. There's a lot of high needs, and I just think that for me, training is really critical, and being open to learning more about our behavioral health population so that they can support them as we age.
And I would just add to that, just echoing, not an expert in that as well, but I don't, I, from, from on the ground, I would say the perspective, right, closer. I don't know if that is the barrier or if there are things legislatively that could be done to support. I mean, we twice a year put out RFPs to support bringing on new RCFE providers. I think that is a stressed and strained, right, network of providers. And I think among them also, they have their own ability to decide who they work with. And again, even those that say that, yes, they are open to working with people exiting from homelessness. Again, like I said, in our county, the assisted living waiver, there's a backlog of 6,000, right? And so again, I think that it's maybe a little a chicken and an egg, right? So yes, what are incentives? What are ways that we can bring on new RCFE providers? But there are capacity and blocks all through.
So some of the words that come to my mind is gerontology training, as you alluded to specifically, but also diversity training, even though diversity, equity, and inclusivity is supposedly a bad word. There are too many older adults from too many different places in life for us to apply a one-fit-all policy. That doesn't make sense. What does make sense, paying attention to best practices. And I just heard about all of these successful stories that made huge differences in a very small population. So what are those lessons? And then tying in those lessons learned with what are the barriers for expanding it? How can we put those lessons? One of the reasons I moved back here to California was because there's treatment here that isn't available in Michigan. How's that possible? Because treatments roll out slowly. It's a very easy to use treatment, but the way the system is set up for medical, I had to learn this, for medical treatments is that specific hospitals get trained to teach specific things to specific doctors. That makes new treatments roll out rather slowly. Here I'm hearing very successful ways to assist the older population. Who's going to be responsible? So we have to be responsible for gaining all those lessons learned and from whatever the top down, apply them in all the different situations. I hear you saying it's expensive. I know that's true. However, a house is expensive and yet we do it. We invest. So if we use more of an investment perspective instead of how we're going to pay for it, we will intend to find ways to invest in upcoming populations because we're all going to grow old. So I don't know the policy, but I know those ideas would be helpful.
Thank you.
Thank you. Commissioner Costa.
Yes, first I want to thank you very much. I've learned so much today. I've mostly worked in health policy, so this is very helpful grounding in housing policy and what it's like. I feel like I have a better understanding of the complex needs of individuals in this who are seeking housing, and I feel like I have a better idea of some of the impediments that relate to provider attitudes and behavior. But there's one question I have that I want to ask CEO Cazares about. You had mentioned at one point that appropriate settings are becoming increasingly scarce, which kind of raised a question in my mind about, is there a supply side problem too? That are there fewer housing providers for supportive housing now than there might have been in the past? And if so, what's going on?
That's a great question. I don't know that there's fewer. I think Lucy made a really good point. It's whether or not they're willing to accept our population. And I have an example. We work with one RCFE in Sacramento. We have 6 clients in that RCFE because they're the one that will take our clients. And I don't know how many there are across Sacramento, but I know there's a lot more than one. And also we still utilize room and boards and board and cares. Board and cares support people with that documentation. And there are many board and cares. Well, when I say many, how many do we have? We have 16 clients out of 200 in board and cares right now. It is so challenging to find board and cares who will accept our clients. So to answer your question, I think both are true. I think we need more board and cares and our CFEs, and I think we need more who would be willing to accept clients with complex needs. And then we go into the Medi-Cal waiver and all of these other things. There's so many complexities, especially with CalAIM, and not that it's a bad thing, but learning how to get there. It takes, for the waiver, I learned that it takes up to 2 years to get a waiver. And we have 2, we're working on several for our clients, but we have 2 who have been accepted with the waiver. So it's so complex. It's such a complex system.
Yeah.
And yes, I think we need more, but more who are willing to accept our clients.
Thank you. We have time for one more question for our panel from Commissioner Parker Martin.
Thank you each so much. That was so informative and, as Michael said, helpful to all of us as commissioners. I want to just follow up on one question, and I think both of you addressed it in a different way. But if there was enough housing and there were not enough housing accepting people with behavioral health issues and some of the very complex issues you discussed, what would be the most critical element to allowing or encouraging those particular organizations to accept individuals with complex needs? What did they need that would allow them to accept, even if there were enough beds, even if there was enough supportive housing?
So, yeah, go for it. Okay. I do think, again, I think it really is setting based, right? I do think that it looks different, right? What would it look like for board and cares or unlicensed care homes, which are certainly used, right? Like they're different. I think it looks different for different settings. I do think there are things that can be done to bolster and add on top of. So for example, somebody living in an RCFE also having ECM, right? Enhanced care manager, right? So I think that there are additional Medi-Cal billable services that we can add on top. And so really being able to work with more agencies to also ensure them that there's external kind of support in addition to what they are able to provide. I think that that's one thing that is maybe is not leveraged enough. And again, all of these systems are imperfect, right? There's capacity in terms of ECM, there's capacity in terms of TSS, right? In terms of all of these things. But I think that it is, I have often found, and this is quite anecdotal, but I'm curious, and I also used to run an older adult FSP, we were talking about this earlier, that a lot of times, whether it's landlords, board and care, SNF, they want somebody to call, right? I think that is a huge, and it's like a very simple answer in some ways, but oftentimes when that individual is having a tough time, right? They want somebody to call who's responsive. And sometimes it is a clinician who can go, and sometimes it's guaranteed that if that person puts a hole in the wall or whatever, that there's funding to be able to support it. So I think that there are some, like everything, I think sometimes the solutions can actually be quite ground level to just say, right? So those types of things, just guaranteeing landlords, guaranteeing providers that there's funding to pay for any repairs, having somebody for them to call to who can respond and again work with them. I think that those types of things often go a long way. We sometimes refer to that as kind of like a case manager for the landlord, right? So it's kind of like the client has support, but then also how do you provide that support to the housing setting as well?
I agree. Our FSP, we have housing, permanent supported housing attached to our FSPs. And we have case managers on site that include peers, older adult peers, and peers and clinical social. All those folks, we have medication management at the site. And so it's easy access, right? So they can be where they are. We also provide social engagement activities, all those things. So I completely agree. It can be that easy having people where they need to be in order to provide support to whether it's a board and care operator, whether it's at RCFE, that having the training, I'm not going to say this enough. I think the expertise, and we can be the experts. We're willing to be there. We're willing to be at the sites. We're willing to provide those services. How we get there is the question.
Hey, one of the things that I did was I joined a training. I forget the name of the organization, but it's peer counseling, peer support counseling, something like that, something with peer support in it. But anyway, what I learned was that that is a piece that's missing many times because an older person can relate to the needs of some of the people that are clients. And so when we say capacity, it sounds physical, but there's another capacity, which is the ability to understand and address what the situation is. And I think what I'm hearing and what I've experienced is that a lot of times we don't have the capacity to understand what's being presented in the behavioral or attitude issues of specific people. And so that's what I think is one of the barriers, that capacity, which is addressable either through training or some of the support that I hear them asking about. And that will be a different kind of investment because um, some of these places are successful in doing what they're doing, but they're so focused that they can't let anyone else in. They can't let in the people that need the most. But if you ask them, which would be another assessment thing, yeah, but what could occur that you could let them in? A certain kind of specialist, as she said, someone to call. Like in our building, there is a new person that can connect people to other services. She's already made a huge amount of difference. And she's, I guess a case manager. She's limited, but in what things that she's done, she can do things residential management can't do legally or whatever.
Great, thank you.
Thank you. As we close this panel, we'd like to take one final opportunity for, again, a positive approach. And one of our commissioners would like to put the question to you off the cuff, but with if each of you in 30 seconds or less, for in the midst of all the overwhelming challenges we've already started addressing, what gives each of you hope? What can you leave us with as a positive way to move forward as we close our panel? So, very briefly.
I'm really encouraged by everything I've read. First of all, in what you're already working on. So I see a prismatic approach, meaning from so many different modalities and focal points, and that's necessary. A both and approach instead of either or is probably the best way because we're all aging, and I really see evidence that we're all invested in making this better. But the other thing that's given me hope is that we're not afraid. We're just so not afraid to deal with this. Every single person that's within our communities and stuff need us. So thank you.
Well said.
Mm.
I echo that. I thank you for making this an important conversation. And even in our own programs, we've seen so much success, and I don't want to lose sight of what has been done. And I too have hope. I see the master plan for aging. I see all of these wonderful things that people are thinking of, and I'm hopeful that we will continue to remember older adults, not lose sight of it's not an afterthought. We're going to bring them as a priority population and recognize them as and having their unique needs. And there's so many of us who are open to that, yourselves included, or especially, I should say. So I thank you for this, and I thank you for giving us hope in moving forward. I am confident that we will conquer this. We've conquered other things. But yeah, I'm super confident that we'll be able to move forward and support our aging population.
And I would say that for me, I think what gives me hope, certainly when I think back the last couple years, I think this work is often boils down to relentless incrementalism, right? This does not happen quickly. And I think seeing the continued furthering of the integration between behavioral health, primary care, housing, senior services, right? Us really coming together. And I think the opportunity to do some innovative work over the last couple of years and seeing the impact and going to those sites and seeing those we've been able to serve. So it always comes back to me for the people we serve, and seeing that on the ground gives me hope. And spaces like this, as was said, with you all to really kind of lift up what's working and then call out and collectively as a community advocate. So thank you all for your time.
Well, and thank the three of you for your time and the fantastic comments and preparation and for getting us started today. We really, truly appreciate it. Thank you.